Assalamu alaikum, everyone. My name is Hassan Shah, and me and my colleague and friend Badr are going to be discussing psychiatry, a quick review of what's important and what comes in your step one exam. He's going to be discussing the second part tomorrow. Today's day one, so I'm going to go over conditioning, ego defenses, childhood onset disorders, psychotic disorders, mood disorders, and anxiety disorders. Okay. So, a quick brief on what to do uh, when it comes to psychiatry. Just let me one second. Uh, in the exam itself, right? So, first thing I'd like to say is about psychiatry is that when you see a psych question, always try to rule out. The first thing is you try to rule out like medical and substance abuse. Okay. So, for example, because a lot of medical conditions and a lot of substance abuse can cause psych problems. So, for example, hyperthyroidism, right? Someone has hyperthyroidism, it can mimic anxiety, it can mimic mania, uh, or corticosteroid use that can also cause mood changes. Okay, so you should always ensure in a scenario that this patient or the person does not have any on any other medical issues or drugs that they're using that is causing this. Okay. So always try to rule that out. Okay. So, sometimes they'll give you a scenario that's actually hypothyroid, and you'll think, oh, this is depression, but you're supposed to check TSH. Okay. So this is something very important for you to rule out. Okay. Number two is see if it affects social or occupation. Okay, so if there's social or occupational dysfunction, this is very important, okay, because a psychiatric diagnosis generally requires that symptoms cause these effects, okay? It causes significant social or occupational dysfunction. So, sometimes someone has odd behaviors but he's functioning well at work, in relationships. It just might be a personality trait other than a disorder, okay? So in the DSM-5, usually, most of the disorders mandate that symptoms lead to significant distress or impaired function. Okay. So this is something that's also important. And the other thing I want to mention is duration. Duration is also very important and something you should keep an eye on, and you'll have to memorize these. Okay. Because it makes a big difference. And many psych disorders are defined by how long the symptoms persist. Or mania versus schizophreniform, or acute stress disorder versus PTSD. Uh, so duration in these conditions is often a deciding factor. Okay. Uh, for the exam, high yield scenarios, usually a lot of psych emergencies and substance abuse, which comes in. And I think these are like, I would assume, or I would say that you should be good with them because these are pretty straightforward conditions. Okay. A lot of psych pharmacology is there as well. And commit these two mnemonics to your memory, which we'll go over: dig fast and sig e caps. These are very important. And I'll go over what these are and more about them. But again, these things are very important and will definitely help you when you're solving a question. Okay. So we'll get straight into it now. Okay. So the first thing we're going to talk about is conditioning. Okay. So what is conditioning? Uh, so behavioral conditioning is basically a foundational concept which describes how organisms learn associations between stimuli and responses. Okay. So the association between a stimulus and a response is basically conditioning. Okay. And you would assume like, oh, why is he teaching us this? This is something we were taught in, like, I guess O levels or A levels, or whatever, IB or SAT or whatever you did when you were taught Pavlov's experiment. And if you didn't, it's okay. But like, I remember being taught this in high school and thinking this is just very useless, just another thing, right? But the reason we teach Pavlov's experiment is because it does have actual effects in medicine, and we'll discuss that right now. So we'll start off with classical conditioning. Okay. So classical conditioning is when a neutral stimulus becomes associated with a unconditioned stimulus to trigger a conditioned response. Okay. So in the experiment of Pavlov, right, the dog hears a bell. Okay. The bell itself is a neutral stimulus. Okay. And the bell is paired with the food, which is a unconditioned stimulus. And the person and the dog itself eventually started to salivate, sorry, which is a conditioned response. I hope that makes sense. Okay. So you have a neutral stimulus, which is the bell, and an unconditioned stimulus, okay, which is the food. These two are all unconditional. And then you condition a response, which is salivating. Okay. This is a classical conditioning. This is called classical conditioning. Okay. And the response is involuntary. Okay. These responses are involuntary. So, for example, for us, for me, for example, if you put a hot plate of biryani, my mom cooks it, I'll start salivating. For, I don't know, various Arabs, I guess you guys like mashi or I don't know. Let's not get into, too deep into that, but, whatever XY food you guys like, pizza or whatever, right? So you guys will start salivating, right? Or fear responses, right? Some people are afraid of snakes, since childhood. And this is a classical conditioning because it's an involuntary response, okay? So clinical examples for this would be nocturnal enuresis, okay? So bedwetting. So we treat enuresis, again, bedwetting, with something called an enuresis alarm, okay? And this concept uses classical conditioning. The alarm is an unconditioned stimulus, which naturally causes a person to awake. Anyone that has an alarm, it will cause a person to awake, right? So an unconditional stimulus, the alarm, is causing a unconditioned response. It's not conditioned within you, okay? This is just a natural response to wake up to noise, okay? Now, a full bladder sensation, okay, which initially would not produce any waking. So a person that has a full bladder, a child who is wetting his bed, he's not noticing this full bladder sensation. For us adults, if you have a full bladder, you'll notice it. Even if you're asleep, you'll go to the bathroom, right? But this child, he has a full bladder. He's not noticing it. And hence he doesn't wake up, okay? So once it's paired with the alarm repeatedly, over time, the full bladder now becomes a conditioned stimulus because the person is waking to the full bladder because of the alarm. But now the alarm and the bladder, it becomes a conditioned stimulus, just like the dog with the bell. Okay. And now itself, so over time, the full bladder itself triggers awakening. Okay. Before bedwetting occurs. So because slowly you'll take away the alarm and the person will just start to wake up because of the full bladder sensation. Okay. And this conditions a child to wake up to bladder fullness. Okay. In classical conditioning, there's another thing that I should mention is extinction, which is when the conditioned stimulus is just is repeatedly presented without a unconditioned stimulus. Uh, that gradually weakens the learned response. So, for example, Pavlov kept ringing the bell without giving the food. The dog would eventually stop salivating. Okay. Now we'll talk about operant conditioning. I hope this is clear, and I'll just move on because I think these are just basic concepts. These are not too tough. And yeah, so operant conditioning. So operant conditioning is a conditioning in which learning occurs through consequences of voluntary behavior. Okay, so your the previous one was involuntary. So salivating, this is something that is naturally coming to. Here, we're teaching someone something, okay, through consequences. Okay, I hope that makes sense. And we'll dive deeper into this right now. So behaviors will be increased or decreased based on reinforcement and punishment. Okay, so and these are important to differentiate between. Okay, so there's something called reinforcement and there's something called punishment. Okay, so reinforcement equals to encouraging a behavior. Okay, if I reinforce something, I'm trying to encourage a behavior. Basically, I'm trying to make it more frequent. Okay, and there's two types of reinforcement. You have positive and negative. So positive reinforcement is giving a pleasant stimulus following a certain behavior. So, giving a child a toy or a golden star or, good behavior or they did good in an exam or whatever.
Okay, so this is you giving positive reinforcement. You're giving a pleasant stimulus to someone for a certain behavior because you want that behavior to happen again. That's you're reinforcing that. Okay. A negative reinforcement would be you are removing an unpleasant stimulus following certain behavior. So positive is I am adding a pleasant stimulus, while negative is you're removing an unpleasant stimulus. So, for example, when you're driving a car and the beeping sound keeps happening, right? To remove that beeping sound, what do you do? To remove an unpleasant stimulus, you do a behavior. Okay. So you do what? You put in the belt. Or another one would be taking pain medications to eliminate pain, uh, wearing sunscreen because you got sunburnt. Okay. All of these would be examples of negative reinforcement, basically removing an unpleasant stimulus following the behavior. Okay. Uh, Now, punishment is different because punishment discourages a behavior. So you're trying to make it less frequent, whereas reinforcement was trying to encourage us to do a behavior. Okay. We're trying to increase the frequency of that behavior. So positive punishment is basically adding an unpleasant consequence. Okay. So, we all come from, I guess, Arabs and Pakistanis and Indians or Desis or whatever background you're from, but people used to get, spanked or let's say lightly, I guess, a different type of love. Let's just define it as that, right? And that would be for, you didn't pray or you didn't do XYZ or you didn't get good grades, right? So that's a positive punishment. Or as they're defined as like, for example, a teenager gets timeout in the and I guess in the West where they get timeout, okay, for or being grounded. Okay. For example, that is a positive punishment. Okay. So adding an unpleasant consequence for a certain behavior or getting a fine or a speeding ticket for running a red light or whatever. Okay. This is a positive punishment. So adding an unpleasant consequence for a certain behavior. Negative punishment is taking a desired stimulus away. So, taking the PS4 away from a child or a PS5 or the new GTA 6, which has not been released yet, taking that away because of bad behavior. Okay. In hopes that it would reduce the behavior. Okay. So negative is you're taking away, positive is you give something. Okay. In punishment. And negative reinforcement is often confused with punishment, but negative reinforcement means that something pleasant is taken away to reward a good behavior. I hope that makes sense, right? So negative reinforcement, you're taking something to reward good behavior. So you're relieving, let's say, some sort of annoying stimulus, okay? And punishment, negative or positive, is always to decrease the behavior, okay? I hope that makes sense, okay? And again, these are important because these are used in medicine, okay? Or they could just ask you directly a question about, something specific like this, okay? This is just the example. This is what we just discussed, classical and operant and regards to it. Okay, so now we'll move to transference and countertransference. So this basically relates to projecting feelings onto other people. Okay. So transference is when a patient projects feelings about an important person onto the clinician. Okay. So someone important in their life, they will see the doctor as. So a classical example would be if, let's say, you're a, doctor, psychiatrist. Okay. And a patient, they start feeling uh, that you're like a parent towards them or a spouse, okay? Because you're an important figure in their life. You're giving them that attention, or you're giving them those conversations you have with them, those deep life talks, and it's a weekly thing or biweekly, whatever, however it's arranged, right? So then they, for instance, they'll start treating you like their father, okay? Uh, and so, for example, for example, a patient, an adult patient who felt abandoned by his father might become angry with a physician if you went for vacation, so they'll just get really mad because they view you as their father who left, right? So in an exam scenario, it'd be like, you remind me of your of my mother and or like my father, and I feel very safe with you. Okay, so this demonstrates what? This demonstrates transference. Okay, basically patients seeing the doctors as their parents or siblings. Okay, countertransference would be the other way around, where the doctor projects feelings onto the patient, uh, you know, because of his past relationships. So maybe a physician who recently lost, like, a sibling or someone important, and they look at the patient that way, and you know, they get maybe the patient misses an appointment or whatever, and they get really irritated by them because of this, because they look at them as, their sibling or whatever. So basically, if a doctor sees a patient as a child or a sibling, that's counter-transference. Okay. Hope that's pretty straightforward. I think that should be easy. Now, ego defenses. By the way, Hella and whoever is managing, there's only 8 minutes left on this call. So again, I don't really know how we're gonna complete this whole thing.
Yeah,
Uh,
I saw. I'm so sorry. We'll fix this though. Don't worry.
okay, so I'll just continue forward. So let me just go. Yeah. Okay. So we're at ego defenses, right? So what are ego defenses? Uh, and this might go a bit personal to a lot of you that might be listening right now, because you'll find some of these conditions or some of these defenses are within you. Inshallah, all of them are mature, but some you might find within your friends and family or whatever. So yeah, listen close, I guess. So ego defenses are basically unconscious mental processes uh, which are used to resolve the conflict, or to reduce anxiety or uh, stress from a unwanted impulse. Okay, so just kind of different behaviors uh, that people do uh, in a form of from stressors, I guess, right? When they're countered by a stress. Okay, some of them are mature, which would be healthy adults uh, should be using them, while others are called immature because these are maladaptive, okay? Meaning they should be seen in children or adolescents, and they shouldn't be seen in an adult, okay? So we'll start off with the immature ones, okay? So the first one I want to talk about would be, in general, immature defenses, you should know, will lead to distort or deny the reality of the situation, okay? So, for example, denial, right? So it's just refusal to accept the reality. And in that way, you avoid the pain of whatever the situation is. So, for example, if a person has chest pain and they have clear signs of an MI and they refuse to believe they're having a heart attack and they delay seeking help. So NMI is, I guess, a bit of an extreme example. Okay. But people that would need to go to the hospital, and you might have family or friends or whatever, and they just deny. Maybe, they have like some sort of, they need to go do a scan, check their diabetes or check their cholesterol, whatever, but they're just too afraid. The real reason is they're actually afraid, but they just don't want to check it. Okay. They just don't want to check their health. Okay. That's denial. Acting out is basically expressing unconscious feelings or impulses through actions, basically, and without awareness of the emotion. Okay. So, for example, if uh, let's say a teenager, he's dealing with divorce. Okay. And he, he will basically start to skip school. Okay. Because his parents are divorcing. He starts skipping school and starts getting into fights, and he'll start to have like act out and be in emotional turmoil because of what's going on at home, but he can't articulate that, right? So that's what he's doing. Okay, instead he's acting out. Okay. Displacement, I think a lot of us might have seen this in real life. You've probably seen it, in which people redirect emotions from the original source to a safer target. Okay. So the classic scenario is a man comes back from work. He's been told off by his boss. He comes back and, tells his wife the cooking is bad, or he gets angry at his kids and, maybe hits his kids, or someone's teaching you and they're very mad at you and they go over the top with your punishment. Maybe you're studying at a medical school and someone comes in and they give you an over the top punishment, for something small, right? That's displacement. They're not really angry at you, but this is the only way for them to actually deal with their anger. So they come out at you, on you, okay? Uh, Projection, on the other hand, would be so recognize the difference between people confuse that, okay? Displacement and projection. Projection is attributing one's own feelings for something that's unacceptable to someone else, okay? So the person sees their own undesirable impulse in someone else and they do not acknowledge it within themselves, okay? So uh, a student who's, let's say, cheating on an exam accuses someone else of cheating, or uh, a man who's angered toward his friend, he's gonna, for example, if a man is, let's say, he works at a job or whatever, right? And his boss, he tells his friends or whatever, his boss hates him or whatever, right? When in fact it's the other way around, where he actually hates his boss, but he's projecting. Okay, so projection is basically, you attributing your feelings to someone else, while displacement is redirecting the emotions someone else gave you to uh, someone that's less powerful or someone that's just a safer target. Okay. Uh, Let me.
Top, can I ask you a question? What is the difference between displacement and acting out? That's the very confusing part.
Okay, what's the displacement between displacement and acting out?
Yeah, the
Well,
difference.
displacement. Okay, so displacement is, as I said, so you're taking emotions because of something that happened to you from usually the scenario of acting out is when you have emotions where you can't really express them. So you're not expressing them on a safer target, right? It's not like I'm displacing my emotions. Okay, I just see something that happened. So let's take the example of the divorce. Okay, but I can't really do anything about the divorce, so I'm just going to act out and do something irrational. Okay, maybe I'll just go get, maybe I'll commit a crime and I'll do something. I'll get caught. But this is not me displacing my emotions, right? I'm not displacing that anger onto someone else. I'm just acting out. I'm completely going out of the, I'm completely in emotional turmoil right now. Does that make sense? While displacement is someone got mad at me or someone did something to me, I'm just going to do the exact same thing to someone that's safer.
Mhm. So
Okay.
basically, in acting out, basically, you do things that are out of your control. Like you start basically shouting, screaming, for an example.
Yeah, yeah. You
Meanwhile,
might skip school and you might get into
yeah,
fights and do all these things. But this is completely
and
different than displacement. Where displacement, someone,
displacement,
let's say, yeah, go
you
ahead.
take it out on someone. Basically, displacement, which happens a lot to me. Basically, someone is mad and he just screams at you for no reason.
Yeah. Someone's mad, they
Yeah,
scream at you for no reason. This isn't acting out. Okay. This is more of like they're probably, back in, like, for example, a lot of families do that. Like, maybe your dad got mad at you and then you go get mad at your brother, your
yeah,
little brother, right? Or your little sister, right? That's displacement.
yeah,
That's not acting
yeah,
out. Okay.
yeah,
That makes sense?
yeah. Makes sense.
Okay. All right, awesome. Okay, so you said the first two slides, where is this?
Which is like before the
The
difference
operating
of
conditions? You mean the
yes, the
operating
operate.
conditions?
Yeah, this one.
Uh, okay. Because it's two, and I want to get done before I want to take off by Salah. If we have time at the end, I'll go over them again. But I think they should be pretty straightforward, and you can watch the
خلاص,
recording
okay.
if okay.
Yeah, yeah,
But if we have time,
sure.
just remind me, and we'll go over them before, inshallah.
Okay.
All right. So I think the last thing we did was this slide. So the next thing I want to talk about would be a couple of the other ones. Okay. So some might not be mentioned here, but let's see. So the next one I'm gonna talk about would be um, regression. Okay. Regression is uh, basically uh, reverting to a earlier stage of development, as from the name. Okay. Under stress, when a person will regress. Okay. So let's say your 6-year-old child who knows how to go to the bathroom. Okay. But they'll start bedwetting again. Okay, because a birth of a new sibling or something, or an adult person, and you can see this, you probably might seen it in, I don't know, movies or whatever, when adult curls up into a fetal position, the fetal position, that's the classical picture of embryology where the, fetus is, legs close to him. In I guess, a stressed out situation, they might curl up into fetal position. When they put the blanket over themselves and everyone just hugs themselves, that is regression, going back into an earlier stage of development under stress. Okay. And this is common in hospitalized patients. Okay, so you see sick elderly people, they might become a bit needy and demanding like children. Okay, this is called regression. You have also reaction formation. Uh, okay, and the ones on the screen, I'll go over a couple. Sorry, let me see. Why is it not working? Okay, I'll go over these as well, but there's a couple that I didn't mention, and I'm just saying them right now as well. Okay, so you have reaction formation. Okay, which is basically replacing something that's unacceptable. So an unacceptable impulse with the opposite. Uh, so an individual, okay, they'll deal with these unwanted feelings by let's say like overemphasizing the opposite. Okay, so a mother who unconsciously resents her child, like she doesn't like her child at all, she'll become overly protected and protective and affectionate. Okay, so she'll give the child, let's say, a lot of love that she doesn't feel like he deserves. She'll buy him stuff with Kida. And then so for example, someone that has like a lot of rage in, for something, and they become like an actual, like basically a pacifist towards that situation, right? The opposite behavior of the impulse they have. Okay, that's called reaction formation. Okay.
हाँ जी.
Yeah, whoever's not mute, put yourself on mute, so that would be
Um,
easier.
I have another example. So for an example, another reaction formation is, for an example, when someone is in love and then he doesn't want to show that he's in love with this girl, so he starts acting like he hates her. Is that another example?
Yeah, that would be. So you see that in I guess kids or whatever, when they like someone, they'll start kicking them or whatever, right? So that's also reaction formation.
Yeah.
Okay. So I remember one of the examples we were given in psych class was like hiring a secretary, like instead of telling the secretary they like them or whatever, they fire them because they really like the secretary. They'll do the opposite. They'll fire them, right? Something like that basically would make sense. Okay. You have another one that's called isolation of effect, which is intellectualization. Okay. Which is sometimes people just strip away all the emotion. And you see this in like a lot of the movies where the guy's like super smart and he has no emotion in anything, right? So he like strips away all emotion and addresses everything with logic. Okay. So, a doctor who has to give like really bad news to someone, they'll focus specifically on statistics and, the details without actually acknowledging the feelings, uh, something like that. Okay. You have something called rationalization, which is, uh, again, this is also something you'll know if someone might be doing, right? Which is like inventing logical excuses for an action or an outcome, okay? So that they can just avoid guilt, right? So, for example, if someone fails an exam, they'll be like, "Oh, it's fine, the exam itself had problems and it's not even that important. I can do this and blah blah blah." So that's just rationalizing something, okay? There's idealization in which the person, emphasizes only the positive qualities of someone or something while ignoring the negative. Okay. So like a child whose parent is like very neglectful, a child whose parent is like, consistently they're always neglectful. He still says like, "Oh, my dad is the best in the world," and they only see the good side. They ignore the bad side, right? They only see one thing that's good, but they'll remove everything that's bad. Okay. Uh, Another one is called splitting, which is seeing others or like oneself as all good or bad. Okay. So as an example says like, okay, all doctors are good, all nurses are bad. Okay. And it's just black and white thinking. Okay, there's no in between. And you'll see this often with borderline personality disorders. So a patient will tell you all the nurses here are terrible, but like Dr. You're like, a saint. You're amazing. You're superhuman, whatever. Okay. Uh, and then later on, if something displeases them, you might suddenly become that terrible person too. You get me? So their views are like split between like an idealized person or a devalued person. There's no middle ground. You can just be perfect or horrible. There's no in between. Okay. Uh, the next one is identification, which is also called introjection. Okay. And this is basically adopting adopting characteristics of a group or a person or their behaviors. Okay, so uh, usually someone that's powerful, more powerful than you, or uh, so yeah, so usually someone that's more powerful than you, people do it to to deal with their feelings of anxiety, or if they have an inferiority complex type of situation. Okay, and this can be healthy. Okay, if it's modeling a healthy behavior. Okay. Or also it can be negative. So if a student starts wearing a stethoscope because speaking like a doctor and whatever because he started attending rotations and he's copying a role model, that's identification. Okay. Uh, that's like the good side to it, right? He's trying to act like them. But a bad example would be uh, a child that's abused at home. He starts becoming a bully towards others and grows up to abuse his own kids and just becomes this bad person. Okay. That's another example of identification. Okay. Uh, so these were the immature ones. Now we'll discuss the mature defenses. Okay. And these are healthier coping mechanisms where the person channels his feelings in a constructive way uh, and in a healthy way, basically. So the first one is sublimation. Okay. Uh, where an unacceptable impulse uh, is channeled into a acceptable or a productive one. Okay. So just as we mentioned, the teenager who's getting abused at home and he has so much aggression, instead of going bullying kids, he becomes a boxer, or he goes to the gym and does something like that, or I don't know, random. He becomes a butcher, or let's say he becomes a surgeon. That could be as well, right? So becoming finding a socially acceptable outlet for that aggression is what sublimation is. Okay. Altruism is basically uh handling your own pain by helping others. Okay. And I had this question in my step one exam where they asked me about altruism. Okay. So these do come. You'll get maybe one or two questions based on this. They're relatively very easy to answer. So yeah. Uh, and what is altruism? As I mentioned, it's like handling your own stress by helping someone else. So, uh, you know, woman who, and you see this a lot, it's common in the West where, drunk drivers, they kill someone's child. So the parents of that child, they take their pain and they channel it and they become like let's say a big organization, or they become this big, uh, support group for other bereaved parents and parents that are going through the same thing, and they start like a whole movement. Okay, so that's basically altruism, or like a mafia boss who starts to becomes more charitable because of everything he's doing. Suppression is basically uh, you consciously decide to uh, suppress or postpone uh, attention towards like an emotion or a need so you can cope with it. So like it's like different than repression that we mentioned previously, because this is a conscious thing you're doing. Repression is more of an unconscious thing where you forget. Okay, so suppression is, for example, a student becomes, they have an exam coming up, and they deliberately put away this fear or this anxiety because, let's say they want to enjoy their time with their family. So they have an exam or in 2 days, and they're having dinner with their family and they can't think about like, oh man, I still have these two lectures left. But he's like, let me suppress this emotion for now and not think about it because I'm going to sit on the table with my family and enjoy dinner and I want to have be in the moment and whatever. And then after dinner, I can, think about this and actually deal with it. This is suppression. Okay. We're actually processing the emotion and be like, okay, for now, I'm not going to. I'm going to take time and then I'll do it after. Okay. So this is a conscious way of actually healthily dealing with your emotions. Okay. And this is considered mature. Humor is also a mature defense in which uh, lightly expressing, uncomfortable feelings to shift, in a joking manner to shift away from the internal, pain or distress the person's feeling. So, by joking about stressful or upsetting situations, you'll acknowledge the emotion in a socially acceptable way. So, medical students, خلاص, everyone over here would, take an exam and, uh, if it's like, oh, if I fail and you guys fail, at least we'll be all together after the exam, we'll have to take it all together. That's just joke to at least, deal with the anxiety that's going on. Okay. You'll have a lot of doctors that work because and they have like, a lot of dark humor, as they say, to cope with, the difficult cases they see and whatnot. Okay. Same goes for like, board exams. A lot of people do a lot of jokes and memes about the board exams. Yeah, that's basically humor. Okay. Uh, so for example, if John is, I'll give you a situation of John, right? So John is 30 years old and he was physically abused by his stepfather throughout his childhood. Okay. And I'll give you a couple of scenarios. If you guys can tell me what is going through his mind. Okay. So scenario A is uh, John, uh, you know, has no conscious anger towards his stepfather, but he complains that my own son seems to hate his grandpa for no reason. So what do you think this is?
Projection?
Exactly. This is projection. Okay. So he's projecting his own feelings towards his own son. Okay. Another one is John feels, uncontrollable rage towards his stepfather, but instead of confronting him, he joins, let's say, a boxing place and he starts to box. What is that? So that
Is
would
it altruism, I guess?
that's no, that's not altruism. Altruism is
Um,
different. This is you're channeling these you're not doing something good for someone else. Altruism is you're
oh,
doing something good for someone else.
oh yeah, yeah,
This would be
Sublimation?
sublimation. Okay, so yeah, exactly. Sublimation. Excellent, Hala. So basically you're channeling these, feelings of rage in a healthy way. You're taking it out on a boxing bag. Okay? Make sense? Okay. For example, another one could be John frequently goes back and he sees his father and he says, I have the best dad. But then next week he says he hates him. He's horrible. Uh, what is this? So one week he said he's the best, the next week he's saying he's the worst. This is splitting, okay? It's split, as the word says. A lot of these, by the way, if you understand the English behind them, it's pretty straightforward. This is a splitting feeling. One week I'm split in my emotions. One week he's in love with him. The next week he hates him. Okay, so this is what we mentioned could be, and this is commonly seen. And again, this is something that's important. That's commonly seen in borderline personality disorders. Okay, so splitting this part right here. Okay, uh, well, I think these are enough examples, and we can move on to the next part, uh, which is a bit about child abuse. Okay, so this also does come up in the exam, and for us to understand what is next, and kind of come up in various scenarios. But we're just gonna discuss the psychiatry aspect of it because there are other pathologies and other, like the green streak fractures and the other fractures and comes up as you have a biochemistry one as well that always looks like child abuse, but it's actually the disease. So yeah, it does come up, right? So uh, although DSM does not this is not considered a diagnosis. Recognizing abuse and child abuse and its signs is very important. Okay. Uh, and the signs include like unexplained injuries that are different healing stages. Okay. Uh, they they're afraid of caregivers, like they have fearful behavior of caregivers, right? They do something and they'll twitch quickly, like the person stands up and this guy is suddenly afraid. Okay, that's a fearful behavior around a caregiver. uh Having sexual knowledge at such a young age, you know uh makes no sense for a 5-year-old or 7, 8-year-old to have that much sexual knowledge at that age. Okay. uh and for the exam purposes, what you need to know is uh, the most important thing you have to do is you diagnose it via observing the child play. And the first step is contacting CPS, which is Child Protective Services. Okay. And you have to know the physician does not need proof. Suspicion alone is enough for you to report it, and you do not need to confront the abusers directly in such a case. Okay. You do not need actual proof. If you're suspecting this, you can say you can directly go to CPS. Okay. As the other examples here are the other ones they mention are, they have STIs and UTIs or oral trauma, anal genital trauma. They have inconsistent stories, or they provide explanations for these in a inconsistent way. Different retinal hemorrhages and subdural hematomas as well can be. Uh, these things. These are all could be signs of uh, what's it called? Child abuse. Okay. And why did we say it's observed through play? Because the child can, uh, express this indirectly through play. So maybe a child draws like extremely violent pictures or family scenes, or he's playing with a doll and he depicts sexual acts with it. Uh, or his interactions with other kids, if he's, let's say, extremely abusive and extremely aggressive towards them, or animals or something like that, right? So that can indicate that this child might have child abuse, been through child abuse. Okay. Uh, so yeah, leading from child abuse, we'll go and discuss a bit about childhood disorders. Okay. Uh, the first one we want to talk about is attention deficit hyperactivity disorder, ADHD. Uh, ADHD is characterized by having inattention, so difficulty focusing, carelessness, mistakes, not listening, okay, that. So inattention and or hyperactivity slash impulsivity. So fidgeting, interrupting, inability to, wait your turn, all these things that is not appropriate for that level of development. Okay. And the symptoms have to start. Again, this is important. Symptoms have to start before the age of 12, and they have to last at least 6 months, and they have to be seen in two settings. So usually the question will tell you about at home and at school. This is usually the scenario, okay, where they're having this problem at home and they'll talk to the teacher and they'll say, okay, they're similar at school, okay? Or it's the other way around where they have it at school and they'll tell you at home also the parent complains of this, okay? Uh, they can give you a scenario in which it's just one setting, not ADHD, okay? Understand that the time, I'll repeat it again. It has to start before the age of 12, has to last 6 months, and has to be manifested in two settings, home, for example, home and school. Okay. Could be any other setting, but the most common ones in the exam scenarios are home and school. Okay. Uh, Yeah, so a child with uh, ADHD, uh, may be constantly on the go, right? The classic is he blurts out answers in class. Like literally the word blurting out answers in the class is repeated in a lot of questions, right? He will blurt out an answer in class and he doesn't listen to the teacher. He fails to complete the homework because he's too distractible. This type of thing, okay? And so in a scenario, if an elementary school child has trouble focusing in school and at home, even though they have normal IQ, like they'll mention that because it matters, right? Normal IQ, uh, if in a different situation, sorry, I saw there's a comment. If there's any comments or questions, Hala, let me know because I can't really see them from here. But yeah, so in a scenario, it's going to be elementary school child has trouble focusing in school and at home, normal IQ. Think of ADHD, okay? Especially if they can focus, they'll tell you they can focus on like, video games because these are highly stimulating tasks, okay? So they can focus on very stimulating tasks, uh, but at school or at home, they're just distracted. Okay. And it's not that they cannot pay attention ever, but it's just they cannot regulate their attentiveness. Okay. That's basically it. Okay. Treatment for this is you basically give stimulants. Okay, so you have, amphetamines and whatnot. Those are the first line medications. You also do behavior therapy sometimes. And yeah, it also sometimes it can go to adulthood and it can present with oppositional defiant disorder, which we will discuss as well. Okay, moving forward. I hope this is clear. In my opinion, psychiatry is it's very important for your step exams, especially I should have mentioned this in the beginning as well, but might as well now. Step one, if you do psych well in step one and understand it well, it will help you a lot in step two because there's a lot of psych in step two and it's quite challenging the way they bring it. But if your psych is good in step one, it should not be an issue. Okay. So yeah, inshallah, this does help you guys out. So the next one is autism. Uh, so autism spectrum disorder, as from the name itself, it's a spectrum. Okay, first of all, that's important to know. So people will have different, uh, uh, you know, uh, symptoms coming out of it. Okay, not everyone's going to be the same. And the important thing is that it's a neurodevelopmental disorder, and it's marked by persistent deficits in social communication and interaction along with restricted repetitive patterns of behavior, interests, or activity. Okay. This is very important because autism is linked with other diseases. So you can tell if in exam scenarios this person has autism or not because of what we just mentioned. Okay. So deficit in social communication and interaction and restricted repetitive patterns of behavior. These are very, very important. Okay. That's why I repeated them. So signs will often emerge in, infancy or when they're a toddler. So a common one is they can't maintain eye contact. Okay, they don't respond to their name. They have a bit of delayed speech. They don't want to play with their peers. They'll just be in the corner playing with their, same truck. They'll do repetitive behaviors like, hands gonna flap around, and or they'll follow like a strict routine. Okay, okay. And as I said, it's a spectrum. So every child could be different. Okay. So, and it ranges from like really severe to where, language and intellectual impairment to those that have like normal intellectual, have that, to those that have normal intellect, sorry. So normal intelligence. And this is what I'm assuming everyone's, or might, most of you have heard of Asperger's, which is ASP, not Asperger's, which is, ASB. It's Asperger's, which is basically being normally intelligent, but just being socially inept. Okay. They can't, you know, they have trouble with social communication. Okay. Uh, and you can see this in, again, because it's a spectrum. You might see it in some of your friends that might be, smart and they'll do everything correctly, but then in social, they don't have social cues. They don't really know how to talk to people. They can't really, you understand what I'm saying? Those are the ones, right? And key features will include is difficulty with, I guess, as I mentioned, social, emotional, so the word is reciprocal. What was the word? It's reciprocal. So basically, they can't reciprocate the love that, let's say, their parents are giving them, or they're having fun with someone else, but they can't do the same thing. So they can't share the enjoyment of the other person. Okay, and they don't understand nonverbal cues. Okay, and fixed interests, and they're doing the fixed behaviors. Okay, so for example, 3-year-old uh who lines up toys obsessively. Okay, and if the order of the toy is changed, he will get really mad and he'll have a fit and just completely melt down. Okay, and or he's like really really interested in just a certain topic, like the trains and when to schedule the trains and something like that, right? And also important to know, I have to throw this in because I guess the medical community, this is known. It's not caused by vaccines. Okay. So just an FYI for those who believe that it's not caused by vaccines. That paper was refuted, even though it was put in Lancet. It was a, paper that was removed. So yeah, it's not caused by vaccines. They ask you this because in scenarios, parents, they'll tell you, oh, parents don't want to give vaccine because they're afraid of autism, blah, blah, blah. How are you going to deal with this situation? Okay. I can see Zainab Ghazi has raised their hand. Yes, Zainab.
I wanted to ask, like here it says you have to early diagnose and intervene. If it's not intervened early on, could that like lead to worsening of symptoms, or does it just stay the same?
So yes, it could. Uh, the idea is early intervention is because you do. So I was going to get to that, right? So you do behavioral therapy, right? So they can improve on their social cues and communication. Uh, but there's no actual cure, okay, to autism, okay? It's just you're training them. You're telling them, okay, this is what you're supposed to do, and this is what so and so forth, right? In the sense, does it get worse? I wouldn't say it gets like, okay, if you don't treat it by 2, they'll just get worse by 10. It remains the same. It's just, habits are easier to change in people, even in yourself. If like, what everyone tells you is like, oh, if you tell your dad or mom or, whoever, someone that's older is like, oh, you can change your behavior or do something like, no, I'm already 50. I can't change anything now. You understand? So it's easier to
Yeah.
affect change in a child or someone that's younger than they're older. But it's not that, okay, if they're autistic at 2 years old, it's just going to get much worse at 20. It just becomes much more harder to deal with. You understand?
Okay. Yeah,
That's
yeah,
what I
got
mean. And again, early diagnosis intervention is important so you can, at that age, before they develop more habits and whatnot, you give them treatment right away. Okay. But there's no actual cure for this. It's just multimodal treatment. So speech, behavior, educational, all those things. Okay. That's basically the treatment. Okay. The next one is Tourette's. Uh, so it's basically, again, this is very specific, again, which you guys have to know these specific things. Okay, so it's a tic disorder, which is characterized by multiple motor tics and at least one vocal tic that persists for 1 year. So that persists for over a year with the onset before age of 18. Okay, I'm going to repeat this again because these are important things. And these small intricacies can take your question for being, correct to wrong. Okay, because of how, small details matter. Okay, so again, multiple motor tics, at least one vocal tic, not more than at least one vocal tic, which has persisted for at least a year, or sorry, at least over a year, and has to be onset before 18. Okay. What is a tic? You have motor or vocal tics, just sudden, rapid, movements or vocalizations. So blinking of the eye, a lot of grimacing, so smiling and back and forth. Okay, shrugging the shoulder, uh, and the vocal ones would be like sniffling, grunting, uh, any sort of other activity. And I think people have seen on video, which is common, or I guess it's not really common actually, but uh, it's been made famous on video where they utter they say words, bad words and bad comments or whatever. It's called lalia, whatever. I guess this is a smart word to know if you're trying to impress audiences with your medical knowledge. So, there you go. But yeah, that's the one that a lot of the YouTube community probably shows you. Uh, DSM-5 does require both motor and vocal tics to be present at some point. It does not have to be concurrently. Okay. I hope that makes sense. Okay. It does not have to be concurrent. So they do not have to occur at the same time. Okay. You can have motor tics. You have to have motor and vocal tics, but does not have to occur at the same time. Okay. Uh, Comorbid conditions that happen with Tourette's that you need to know should be ADHD and OCD. They do occur with them. And they sometimes mention it that, oh, you're treating this, so what else might they have? Which is ADHD and OCD. Treatment is if it's mild, you usually do educational and behavioral therapies. Moderate to severe, you start giving out anti-dopaminergic medication, like risperidone or haloperidol, which can help the tics. Other options would be VMAT inhibitors. So that would be your tetrabenazine. These are used mostly because they have better side effects. So tetrabenazine and other VMAT inhibitors. And for those, because I mentioned comorbid conditions like ADHD, so for milder or for treating people that have ADHD along with a tic, you give alpha 2 agonists. Okay. So you have your clonidine and guanfacine. Okay. Uh, and these are usually used in children, I guess. It's a bit better for initial therapy for them. Okay. Uh, again, I'm specifying these things again specifically because these are important. Both motor and vocal tics together distinguish Tourette's from, chronic motor tic disorder, which is just motor tics, or chronic vocal tic disorder, which is just vocal tics. Okay, so a classic vignette is going to be like a 9-year-old boy with a history of, let's say, uncontrolled blinking, and then he has like throat clearing at some other points for 2 years is Tourette's, okay, and he has trouble sitting still and concentrating. That's adding ADHD to it, okay. And yeah, that's basically Tourette's for you, okay. Uh, Now we're gonna go over a bit of oppositional, defiant disorders. So oppositional defiant disorder is the first one, and so it's basically talking. So it's basically a pattern of angry, irritable mood, argumentative, or defiant behavior, or vindictiveness, which is towards usually authority figures, uh, and this lasts at least 6 months. Okay. So these kids are actively defiant. They lose their temper. They argue with adults. They don't comply with rules. Annoy other people, blame others for their mistakes. Uh, and you need to know, importantly, oppositional defiant disorder does not, and I'll repeat this again, does not involve serious violation of other people's rights, and this is what it differentiates. This is what differentiates it from conduct disorder. Okay, which is something we'll learn moving forward in probably the next slide. Okay, but again, ODD does not involve serious violation of other people's rights. Okay, I hope that is clear. So ODD children are not aggressive towards other people or animals, do not destroy property, do not steal. Their behavior is more like, I want to be oppositional, I want to be difficult, that type. Okay. Usually starts in school years, early school years. You manage usually by, therapy. There's different types of therapies. There's parent therapy, so something called parent management training, and discipline strategy training, basically. Um, but see, so scenarios usually like, oh, a child who constantly argues with teachers and parents, but does not hurt anyone or break the law. Think ODD. Okay. Conduct disorder, on the other hand, is a more severe disrupted behavior disorder where the child or the adolescent repeatedly violates the basic rights, okay, of others or of the social norms, okay? And this would include being aggressive and destroying stuff, being deceitful, being, a violator of all sorts of rules, breaking the law. The examples would be like the guys just, bullying, fighting, using weapons, being cruel to animals, vandalism, just, breaking windows and setting fire to things, and just a complete, let's say, hooligan. The dude's like on some Ted Bundy stuff. Okay, that's who conduct disorder is. If he's Ted Bundy, conduct disorder. Okay, if he's not Ted Bundy and just like a regular kid that's like, mad, think ODD. Okay, uh, and on top of it, because he's Ted Bundy, no remorse. Okay, they lack remorse. These people, conduct disorder, they do not have remorse for their behavior. Okay, so they might not have empathy for them. Okay, and again, note the age. Conduct disorder will be diagnosed before 18. Okay. After 18, if the individual is 18 or older and he's exhibiting similar symptoms and he's doing all sorts of things, this person will be diagnosed with antisocial personality disorder. Okay. So please, this is why I mentioned the ages are very important. You'll get the similar question. The person's 18. You put conduct disorder wrong. Even though you had it right, you thought the correct way. The answer is antisocial personality disorder. Okay. Personality disorders will be discussed tomorrow, but just an important thing I'm trying to indicate to you guys is how important ages are and how quickly they change. Okay. So conduct disorder will be diagnosed under 18. 18 and above, similar behavior, antisocial personality disorder. Okay. Next is disruptive mood disorder. Okay. So a child, so disruptive mood dysregulation disorder is the first one we'll discuss. Okay. So it's a childhood condition usually, which has severe recurrent temper outbursts, whether they are verbal or behavioral. Okay. And are grossly out of proportion to the situation. So they're persist, and this also, sorry, so along with the severe recurrent temper outbursts, they have persistent irritable or angry mood in between outbursts. Okay, so they are consistently angry the whole time, and they have recurrent temper outbursts. Okay, so the key features would be the outburst occurs on average 3+ times per week, and they have to begin before age of 10. The diagnosis cannot be made before the age of 6 or after the age of 18. Okay, I'm throwing a lot of numbers at you guys. I'm sorry, but when you do a question, this is going to be a bit confusing. So no, disruptive mood dysregulation disorder, DMDD, 3 times or more a week, has to be present for 12 months, has to be before the age of 10, but not before the age of 6, or after the age of 18, I guess, or after 18 doesn't count, but because it's before age of 10, so not before 6. Okay, so an 8-year-old child, for example, who has tantrums 3 times a week and described by parents and teachers as all day he's constantly irritable and angry every day, most likely DMDD. Okay. uh
what differentiates this from oppositional defiant disorders, someone might ask, is because even though both have like, angry outbursts or irritability, is that DMDD is characterized by the additional thing, which is being constantly angry or irritable in between outbursts. ODD kids, they can be defiant and have their own issues, but will not be angry constantly. Okay? So think of a DMDD as like an extreme version of ODD with like mood disorder features. Okay, constantly irritable. Uh, Intermittent explosive disorder, uh, in contrast to DMDD, which is a pediatric diagnosis. IED is typically a adolescent or adult. Okay, so must be at least 6 years old, but is usually seen in teenagers. Okay. Involves episodes that are, sudden severe aggression, could be physical or verbal, and will be out of proportion to any provocation. Uh, so the explosive outbursts are going to be impulsive, uh, and they usually last, they're not that long. Okay, they're short periods, and the person feels remorse. Okay, that's important. These people feel remorse and they feel embarrassed about what they did. Unlike conduct disorders, there's no motive, there's no aim. It's just an impulse control issue here. Okay. Uh, Classic scenario would be like a normal person, calm adult. He just snaps and just assaults someone over like a minor comment or something small that happened. And then afterwards they just feel really sad about it. Okay. And in between episodes, their mood is perfectly fine. They don't have any irritability or anything. And so IED is intermittent episodes with really for guilt afterwards. DMDD would be persistent anger throughout and then frequent outbursts. Okay. Uh, Treatment for these is usually SSRI or mood stabilizers. You also do CBT for them, cognitive behavioral therapy. So in an exam, if you see an adult who has, episodic violent outbursts, and he's usually normal otherwise, and he feels really bad after it, this is IED usually, okay? Uh, on the other hand, if it's like a child, chronically irritable, then it might be DMDD if he has like, episodes of aggression and whatnot. Okay. So in summary, for the disruptive behaviors, ODD is so oppositional defiant disorder is defiance without major aggression. Okay, you're not doing like serious aggressive stuff. Uh, CD, compulsive disorder, uh, is basically no, sorry, conduct disorder, CD, is basically serious violation of other people's rights and societal norms. Okay. We have DMDD, which is temper outbursts along with being persistently irritable throughout. And then IED is you have outbursts, usually in older individuals, but you're normal without the outbursts. Okay, I hope that makes sense. And I hope that simplified it towards the end. Okay. Uh, if we have no questions, I'm going to move forward towards psychotic disorders because this is a bit heavier, and hopefully we can. Let me just drink some water. Okay. So, uh, psychotic disorders, we're going to discuss schizo and the different spectrums, and then the delusional disorder. Okay. So, in psychotic disorders, the abnormality is usually in perception or, excuse me, thought content. Okay. So a lot of delusion, a lot of hallucinations, a lot of disorganized thinking. Uh,
this distinguishes them from often so how to differentiate them uh would be timelines and the associated symptoms. Okay, that's a big way to differentiate them, and we'll discuss this right now. So the first one is schizophrenia. Okay, uh again, timelines is very important. 6 months, 6 or more months, so of illness with 1 month or more of active symptoms. Okay, unless the person is treated. So the active symptoms are going to be described by positive symptoms or negative symptoms. And again, these are important to know because this is how they'll be mentioned. What is positive? No one's going to describe to you positive or negative. It's just going to be symptoms mentioned. So you need to know which is positive, which is negative. Okay. So positive symptoms, delusions, having a fixed false belief is a delusion. You have hallucinations as well in positive, which is perceiving something without having external stimulus. Okay, so most often you'll have auditory hallucinations in this case, in this schizo. They have disorganized speech as well. This is another positive symptom. So, uh, what's called word salad or not being able to associate words correctly and having disorganized behavior as well, like catatonic, being catatonic as well. Okay, if that makes sense. So I'll repeat these again. So you have delusion, hallucination, disorganized speech, so word salad, and disorganized behavior. Okay. Negative symptoms would be flat affect, which is just having a flat face. That's what flat affect means. They have reduced emotional expression, basically. Okay. Uh, Lack of motivation. So they don't really feel like doing anything that's called avolition. Okay, that's lack of motivation. They have something called poverty of speech, which basically is alogia or elegia, however that's pronounced. Okay. Uh, Anhedonia is basically like lack of motivation, not feeling like, doing anything. And social withdrawal, which is, just not being associated with anyone else in society. Okay. And these are the ones that often persist. So negative ones are the ones that persist longer and cause long-term disability. Okay. So schizophrenia is 6 months or more of the illness, along with 1 month or more of active symptoms. Okay. And to diagnose, you need at least two of these symptoms with hallucination, delusion, or disorganized speech being one of them. Okay? I'll repeat that. Diagnosis requires two or more of the following, or the ones we mentioned, okay? Symptoms, along with one symptom or more from hallucination, delusion, or disorganized speech. Okay? And these need to be present, again, as I mentioned, for at least 1 month with continuous disturbances happening for 6 months. Okay? So schizophrenia usually presents in late adolescence to mid 30s. So let's say 20s. Okay, above 20s, usually that's when the person might have schizo. That's when, like, around 20s to 30s is when the patients present. Okay, there's usually a prodrome, which means preceding. You'll have a gradual decline in societal function. They'll start to have paranoid delusions, like people are, following them or about to harm them. They have bizarre delusions and they may start speaking to themselves. Okay. Uh, there is functional decline, okay, which is very important. Schizophrenia causes marked impairment in social or occupational function. Okay. So a person who has schizophrenia is not going to be able to, hold a job or maintain self-care And I mean, interestingly enough, there was a there was a situation in one of the hospitals my friend told me about, and this patient had schizophrenia, and he was really early diagnosed. And I forgot the exact medication they gave him. I think this is in Saudi Arabia. My friend saw the patient himself, and this guy had an episode, and his brother was the only one that knew about it. So they kept it quiet, did not tell anyone of the family. No one knew except him and his brother. They took him to hospital. They treated him, and he caught it on like really early on, really early on. And the doctor was like, "You're very lucky that you found out really early on that you have schizo. We're going to start you on the medications." And mashallah, he's married. He lives a normal life. He's on meds and he works a job and everything. And the only people that know about this, I guess, are you guys now, me and my friend, and whoever else is listening. I guess, yeah. But it's a pretty interesting story. That's why I said, but that does not mean that this is a common thing. Uh, so yeah, functional decline is very important and is key. So schizophrenia causes marked impairment in social or occupational functioning. Okay. Uh, and the first episode of schizophrenia is usually, young person, uh, a college student, usually in the exam. He becomes socially isolated, starts hearing voices, and will start showing weird behavior for 8 months. That's usually how, its first episodes usually present.
Can I ask you a question?
Uh,
I thought the
sure.
hallucinations, usually I thought the hallucinations is basically start th seeing things, but it turns out it's only auditory, like he can see perfectly fine, or does he see also images that no one else sees?
Okay, so hallucinations themselves is perceiving something, so having a perception without external stimulus. Okay. Do they have visual hallucinations? They could, but in schizophrenia, a lot or majority of the hallucinations are often auditory. Okay. They'll be hearing voices. Okay. This is the most common thing in schizophrenia. That does not mean they cannot see something. Okay. Uh, Number two is having a delusion is a possibility in which they believe. So having a fixed belief. So delusion is having a belief that's false, but I'm fixed in that belief. For example, believing that he's being followed. This is a fixed false belief that you cannot, do you know he's seeing them? Maybe it's not a visual hallucination, you get me? But it's a fixed false belief that might make you think, okay, this is a visual hallucination, but it's not. It's a
Yeah.
delusion. But majority of them, to answer your question, are auditory, okay, in schizophrenia. Okay. Uh, the pathophysiology in quick is that there's increased dopamine activity in certain pathways. You have the mesolimbic hyperactivity that is kind of linked towards these positive symptoms. Again, I'll mention this again, mesolimbic, because this is kind of important. I remember there was a URL table on it that's related to the treatments of it. So mesolimbic is related to positive, mesocortical pathway is linked to the negative symptom. So increased dopamine basically is causing positive symptoms, decreased dopamine is causing negative symptoms, decreased dopamine is mesocortic, while positive is mesolimbic, okay? Uh, and the treatment is usually antipsychotic, medications, and I think that'll be discussed more in towards the pharmacology section of that'll be tomorrow. And something else I want you guys to know is genetics is the most important factor. It's extremely correlated to genetics. They've also seen adolescent cannabis use is associated with increased risk of developing schizo. So these are the two things that you need to know, okay? But genetics is the most common one, okay? And cannabis use can also be done, can also be caused. Now, yes?
I have a question. So, I know that when I was studying with the doctor, he said that inflammation is also going to be the reason for schizophrenia. But for an example, kind of like an infection trigger the psychosis also?
Okay, so psychosis, yes. Schizophrenia, from my knowledge, no. Maybe you can find case reports or whatever about it. Psychosis is different. Okay. You said psychosis. So psychosis,
Yeah,
yes.
yeah. But I mean, like, when the doctor was talking about it, usually happens through stress, like genetics. We have a gene, and then through stress, it's gonna lead to having, it's gonna like trigger them. So I don't know if like if you get an infection and then after the infection you're gonna start being inflamed. So can an infection lead to like triggering of having these schizophrenia? That's what I'm asking. Because like I remember the doctor saying like there are some specific triggers to the genes that leads to inflammation of the brain. But I don't know if like also like infection can trigger this.
From my knowledge, no. Again, from all that I've studied and whatnot, no. The doctor definitely knows more than me. So if he has told you that, maybe. I'm assuming there might be some case reports you can find of an infection leading to it. But yes, in general, inflammation, look, inflammation is the root cause of almost every problem in the body. Like, yeah, every pathology, always at the end of the backwards, you'll see inflammation. Uh, but for your exam purposes to know, genetics and heavy cannabis use. No one's gonna ever ask you of a scenario in which the person had uh, an infection leading to schizophrenia. That does not happen. Okay.
So cannabis basically like marijuana and
Yes.
drugs, you're right?
Marijuana, hashish, marijuana, these things. Yeah.
Yeah.
Not drugs. So not other drugs. These are the specific ones. Cannabis is marijuana and hashish. In the exam, they'll just tell you like marijuana basically.
Okay.
Okay. Uh, okay. So the other ones I want to discuss here would be the brief psychotic disorder. Okay. So this is something, let's say it's one step shorter. So symptoms less than 1 month. Okay. And eventual full return to, you know, the pre level of functioning before this. So 1 month of less than 1 month of having symptoms, right? So it's often triggered by extreme stress. Okay. So it could be drugs, could be someone passed away. You mentioned an infection to that level. I don't know again, but this could happen in a person with an infection. Okay. There are some that can. Okay. So by DSM-5, it requires at least one psychotic symptom, the ones we mentioned. Okay. So delusion, hallucination, disorganized speech. Okay. That lasts more than a day, but less than 1 month. Okay. So one of these symptoms lasting more than one day, but lasting less than a month, and then the person eventually recovers. So classic scenario, person has a psychotic break for 2 weeks after, let's say a death of a family member. He starts to hallucinate, delusion beliefs, delusionally for a short while, and then he resolves. Uh, that's basically. So if you see any psychotic symptoms that last only a couple of weeks, usually think of brief psychotic disorder. Uh, this could also be acute stress disorder, uh, but those are a bit different, okay? Uh, and try to always exclude delirium or like medical issues when it's a really short one. So like brief psychotic disorder, when it's really short, try to exclude something like delirium from it, okay? But again, I'll repeat this again. So more than one day, less than a month, one positive symptom so either hallucination, uh, delusion, disorganized speech. Okay. And this resolves and they go back to pre-morbid level of functioning. Okay. The next one would be schizophreniform disorder. So it's essentially basically it's like schizophrenia in formation. Okay, that's how I look at it, right? It's like their symptoms are basically like schizophrenia, except they last 1 to 6 months. Okay. If the symptoms resolve in 6 months, it's schizophreniform. If they persist and they go beyond 6 months, schizophrenia. Okay. A little bit statistics for y'all. 1 in 3 recover within the 6 months. 2 in 3, 2 out of 3, they go towards schizophrenia. Okay, or schizoaffective. Uh, on exams, if the duration is going to be like 3 months of hallucination and delusion with functional impairment, usually schizophrenia form. Okay. So think of it as schizophrenia information. Schizophren information. Okay. It's on the way. It can happen. It might not. Okay. That's schizophrenia. That's schizophrenia form for you. Then you have also schizoaffective disorder. Okay. Uh, think of schizoaffective as the person has schizophrenia, but they also have a mood disorder. Okay. So it's basically schizophrenia with concurrent mood episodes. But this is very important. But the psychotic symptoms also occur for at least 2 weeks in the absence of any major mood episodes. Okay? I'll repeat this. Schizoaffective disorder is schizophrenia with a concurrent mood symptoms, right? Mood episodes. But the psychotic episodes, the psychotic symptoms, the ones we mentioned, delusion, hallucination, disorganized speech, they have to have occurred and they have to occur for at least 2 weeks in the absence of any of the major mood episodes. Okay. So in other words, the patients have episodes of like depression or mania in addition to psychotic symptoms, but they've also had delusions and hallucinations even when their mood is stable. Okay, does that make sense? And this is how you differentiate schizoaffective from like a mood disorder with psychotic features. In schizoaffective, psychosis isn't always tied to mood, and there's like a period of pure psychosis. While in the other one there is mixture of both. Okay. So for example, a patient hears voices and has delusions consistently. And then let's say sometimes during this course, he also gets really depressed. But even when he's not depressed, he still hears voices. That's schizoaffective. Okay. And again, treatments again is usually antipsychotics, mood stabilizers, antidepressants and whatnot. And yeah, that's the treatment for that. Let me see. Okay. Yeah, these are the ones we're discussing right now. Sorry, so I'll keep it here so you guys have
Now, can I ask you one last question? In brief psychotic disorders, so after it gets resolved, is there any chance like it comes back again? Like it might like just خلاص he have it once in his lifetime and he's not gonna have it again, or like he might have it like another another time, and then this second time it might develop into schizophrenia.
So from what I know, I don't have any like specific statistics on the amount of people that go from brief psychotic disorder towards uh schizophrenia. But from my understanding, yes, it can always happen again. Okay. Does it increase the chances of it happening? I don't know. So I don't want to tell you that, hey, if you had brief psychotic disorder once, does that mean you'll have a 5% increase to as compared to normal population? I do not know that. And I also do not know what is the statistics behind if you had a brief psychotic disorder, and does that mean you'll have a higher chance of having schizophrenia? So I'm sorry, but I don't want to, tell you this, and it's wrong information. So maybe this is something you can look up, and let us know. But yeah, uh, from my reading and from my understanding of taking the exams or whatever, they never usually go into that. So it's just you just need to know if hey, is brief psychotic or is it more towards something schizophrenia form or schizophrenia or schizoaffective. Okay.
Okay.
I'll discuss something here as well, which or should we keep it? Okay. So because I mentioned it, I'll talk about it right now as well. Okay. So we mentioned schizoaffective disorder. So it's basically schizophrenia with mood. And there's something else called major mood disorder with psychotic features. Okay. So this is not a separate psychotic disorder. but it's a differential, okay? It's more of a mood disorder, so it's major depression. So in a person that has major depression or bipolar, sometimes they have psychotic symptoms, delusions slash hallucinations, okay? So, and they only occur during the mood episodes. This is the big differentiation between schizoaffective and this major mood disorder with psychotic features, okay? So, for instance, a person, has hallucinations, but this is during his manic episode or when he's only severely depressed. If psychosis stops when his mood improves, this is it's a psychotic feature of the mood disorder, not a schizophrenia or schizoaffective disorder. Okay. Uh, you don't need to like really memorize it. It's pretty straightforward. Look at it in this way is okay. Did a person have 2 weeks of psychosis without mood symptoms? If yes, okay, this is schizoaffective disorder. If no, major mood disorder with psychotic features. I hope that makes sense. Uh, if not, do let me know. Uh, the next thing I wanted to quickly discuss before we go into delusional disorder. Again, this will be addressed tomorrow, but let me just mention it. Is schizotypal personality disorder, which is sometimes mentioned, it's a type of cluster A personality. Okay. And it involves having like odd beliefs and being like eccentric, like magical thinking type stuff, like having like bizarre fantasies as well. But there's no full-blown delusion or hallucinations happening. Okay. And it's a chronic thing, but it's not severe. Uh it's just the person's a bit odd. Okay, that's basically it. Uh, while schizophrenia is like, an actual disorder and there's actual like massive problems the person faces, okay? And there's functional impairment, psychosis. Well, none of these things are happening in a person who has schizotypal personality disorder. He's just a bit different, okay? I hope that makes sense. Uh, the last one I want to talk about would be delusional disorder. Uh, and we mentioned what delusions are, and I'll repeat them again, is having a fixed false belief. Okay? So a delusional disorder is characterized by having one or more delusion for 1 month or more without having other psychotic symptoms. And the person's functioning life is otherwise totally fine. Okay? So he's completely fine, but you know, let's say he'll believe that, I don't know, like whatever XYZ, like they'll believe that is some sort of like Taylor Swift or XYZ is in love with them. But other than that, they're like a chemical engineer and they're working perfectly fine and their life is completely fine, except for having one bizarre thing. Okay. And their behavior is completely normal. They don't have any bizarre or odd behavior. Uh, and the delusions are often like not bizarre in that sense, right? Like in sense they're plausible, but they're untrue. Okay. Uh like believing someone's being conspired against or like being cheated on or poisoned or something. Okay. S- like yeah, it's just a disorder in which you just have a delusion and nothing else for 1 month. And other than that, you're perfectly fine. Your life is not affected. You're just, you're chilling. There's no hallucination, there's no disorganized speech or behavior. The person's perfectly normal. Okay? Usually presents with like middle-aged man, as I mentioned, like an engineer or whatever. He'll believe like, oh, the FBI is like spying on him. That's it. Everything else, his family's normal, his wife's normal, blah blah blah. It's just this. Okay? Uh, so yeah, those are the basically psychotic disorders. And in summary, keep on this page so it's easier. Timeline is king in these disorders. So If it's less than 1 month, brief psychotic disorder. 1 to 6 months, schizophreniform disorder. It can become schizophrenia, may not become schizophrenia. It is in formation. Schizophrenia is more than 6 months, and so is schizoaffective. The difference is schizoaffective has mood symptoms, while schizophrenia doesn't. Delusional disorder is just having one delusion, everything else is normal, your life is functionally okay. Okay? I hope that makes sense. And we can move on towards mood disorders, which is basically we're going to discuss manic and depressive episodes. Okay? So when you talk about mood disorders, you're basically talking about, the disturbance in emotional states. Okay? And this becomes a bit tricky because the USMLE really focuses on major depressive disorders, bipolar disorders, and stuff that's related to it. So let's start off with bipolar disorders, and that brings us to mania. So bipolar 1, okay, is characterized by having mania. Okay, someone sent something on the chat. Okay, someone said, can we have a break, please? Uh, we can have a break. I wanted to take the break for Salah, which should be in a bit. So
Yeah, doctor, we can do that if you don't mind.
yeah, yeah,
Yeah.
I don't mind taking a break for prayer. I was going to take a break for prayer anyways, so we'll do that and
For
then we can
Asr,
continue.
we can, yeah.
Yeah, for Asr. Yeah. So I think Asr still has time. Let me see the
Yeah, yeah.
exact time of Asr. Asr
Yeah.
prayer. Yeah, there's like 20 minutes in Asr. Okay. So inshallah by then we're done with mood and then we'll have one more left and you guys are free to go, inshallah. Okay. Okay. So in mood disorders, we're talking bipolar right now. So bipolar disorder, bipolar 1 is characterized by mania. Okay. Uh, what is mania and how is it different from hypomania, which is the big keyword for bipolar 2? So a manic episode it's a distinct period in which a person has like certain abnormalities and is persistently, it feels really high. They feel elevated, okay? They feel expansive, uh, and they have like irritable mood, increased energy, and they're like super goal directed, and it lasts a week. It lasts at least a week, okay? So during this duration, any three of the symptoms are going to be there, okay? So dig fast is the mnemonic. So dig fast. So D is distractible. I is being impulsive, so uh, impulsive and indiscretion, which is they take part in high risk and pleasurable activities with often bad consequences. So they'll tell you they're gambling all their money away, or they'll spend 10,000 on like buying stuff, or they'll have like sexual indiscretions. Okay, so these type of things. Okay, as a word is they mention here hedonistic. Okay, there also G stands for grandiose, so having like inflated self-esteem, so really so superior, blah blah type of thing, right? They also have flight of ideas, which means basically they'll jump between topics. They'll go from here to there. They'll say this, and then they'll go move on to the next one. Okay, they can't stay. Increase in activity, or psychomotor agitation. They'll also not sleep, so they'll basically be like, "Oh, I haven't slept for like this much, and I feel fully, rested, even though I slept for like 2 hours and been just functioning the whole week." And they'll be very talkative or they'll have pressured speech. Okay. And please understand that when a person is having a manic episode, it causes severe functional impairment. Okay. They will have to be hospitalized. If the person is hospitalized during their bipolar, this is على طول manic episode. Okay? This is important because this is how you differentiate it from a hypomanic episode. Okay? In a hypomanic episode, hypomania is basically, a milder form of mania. The symptoms are similar, so elevated and irritable mood, increased energy, and you have the three or more dig fast symptoms. But two things, they last at least 4 days, and there is no marked impairment. Okay? There will be no psychotic features, and the person can often still function. Okay? This is very important. The manic episodes last at least a week, will have marked functional impairment, okay? And they may have psychotic features. Okay, I hope this makes sense. Now, in regards to what is bipolar 1 is at least having one manic episode, which is diagnostic. Having at least one manic episode is diagnostic. Having depression or depressive episode is common but not required for diagnosis. So basically, if you have one manic episode, which is described by having the dig fast symptoms, the three of them, for at least a week, with marked impairment in functioning, along with they may or may not have psychotic symptoms, this is a manic episode, which is AKA bipolar 1. In bipolar 2, they will have hypomanic episodes. So basically, bipolar 2 is having at least one hypomanic episode and one major depressive episode, and do not have any history of full mania. This is important. No history of mania. Okay? Because if they do have mania, خلاص على طول, that is your manic episode, which is على طول bipolar 1. Okay? No marked impairment, no psychotic features, no hospitalizations. If anyone is being hospitalized, that is by definition mania, not hypomania. Hypomania, people are, they might be unproductive or whatever, but they will not be disruptive. While mania people are disruptive. Okay? So bipolar 1 is at least one manic episode. Does not have to have the depression episode. Could be, could not be. And often cycles along with depression episodes, but depression is not required. Okay? So even one single lifetime hospitalization or one single episode of mania qualifies you for bipolar 1. Bipolar 2, one hypomanic episode and at least one major depressive episode with no full manic episode. And often these people, you'll think, oh, this guy just has like recurrent depression until you see a hypomanic episode. Okay? I hope that makes sense. There's something called cyclothymic disorder. So it's basically a chronic fluctuation of mood disturbances for 2 years with periods of mild hypomanic symptoms and periods of mild depressive symptoms. But it never meets the full criteria of mania, hypomania, or major depression. It's like a milder, long-lasting form of bipolar. And the person has like ups and downs, but not severe enough to call it like a manic episode or a major depressive episode. And they're symptomatic for at least half the time and with no long like normal periods. Okay, so it's basically fluctuation between different moods for 2 years. Okay. In regards to treatment for bipolar, you got to know is lithium is so mood stabilizers are the biggest thing, and lithium is classic for bipolar 1. And it treats acute mania, and it also helps prevent recurrences, and reduces the risk of suicide. important. Okay? I say this is important because, again, they'll give you a whole question. You have to figure out what the diagnosis is, and they'll tell you some medication is given. Which one of these is the one that, reduces suicide risk? Or they'll tell you a medication is given that reduces the risk of suicide. Please tell me how it works, or whatever is the mode of action, or all that, right? Something like that, okay? Or step two is gonna be like they'll give you the whole situation, and they'll be like, what medication would be the best to reduce his risk of suicide? Okay. The other medication that's usually given is also valproic acid, carbamazepine. These are first line for acute mania, uh, and prophylaxis, and especially in bipolar 1 where severe mania or rapid cycling is happening, okay? Uh, Atypical antipsychotics are also used, so risperidone and quetiapine. You have bipolar depression, which is a bit tricky to treat, okay? Uh, you have atypical antipsychotics like quetiapine and lurasidone. You also have lamotrigine, okay, which are all used. Uh, so the thing that is important is that I want you guys to know would be you never give an antidepressant alone to a bipolar 1 patient. This is very important, and this is a question that they will ask you. So please know this. Antidepressant alone to a bipolar 1 patient is a big no-no. It can trigger a manic episode. So even in a patient, when you diagnose them with depression, you have to make sure of the fact that they've never had manic episodes before, just so that you know these people are not bipolar 1, so you do not give them antidepressants. So no antidepressants alone to a person who has bipolar 1, okay? It will induce mania. Uh, I mean, to be honest, there's a lot we can say about treatments here. Uh, Lithium, for example, has a bunch of side effects. You'll have tremors and hypothyroidism and whatnot. Uh, the Epstein anomaly, heart. Sorry, so it's the anomaly of the heart in a newborn, if it's taken during pregnancy and whatnot. Carbamazepine causes agranulocytosis. Uh, so often, so you'll have to kind of know these when studying this, but for now, I think it's okay. This will be discussed, I guess, later on. Uh, so yeah, just know mania, 7 days, unless the person's hospitalized because of their manic episode. Hypomania, 4 days. Uh, Not as severe, no functional impairment. I hope this was clear for everyone. Bipolar part. Okay, we're gonna move on to major depressive disorder now. So, major depressive disorder, or MDD, is characterized by at least 2 weeks or 2 weeks of 5 or more of the SIG-E CAPS symptoms, with at least one being depressed or anhedonia, which is irritability, okay, in children, or irritability in children. Anhedonia is basically, I don't want to feel like doing anything. That's basically anhedonia, okay? Sorry, I was drinking water. So we mentioned SIG-E CAPS. What's SIG-E CAPS? As you can see here, it's sleep disturbance, decreased in pleasurable activities, so anhedonia, guilt, decreased energy, decreased concentration, appetites, uh, and weight changes, psychomotor retardation or agitation, and suicidal ideation. As I mentioned, screening for previous manic episodes is very important because of the treatment. Okay. Uh, the episode must cause, clinical significant distress or impairment. So, an MDD is episodic, and, episodes typically last like months if the patient's untreated, and the patient can have multiple episodes in, their life. Uh, in MDD itself, there is no hypomania or mania. Okay. Uh, there are some atypical depressions where mood can brighten, to positive events and have symptoms like increased appetite or hypersomnia or heavy feelings in the limbs. So leaden paralysis, that's what's called. Okay, so they can have heavy feelings in their limbs and hypersensitivity to rejection. And sometimes, so for those people that have atypical, we give them a different type of treatment. It's called the MAOIAs inhibitors, basically. For usual, it's SSRIs, okay? What is important is suicidal ideation or suicidal risk is always important to check for in patients with MDD. Uh, it's always a risk factor, and the risk factors for uh, suicide is usually you'll see older people, they're the ones that are using substances, uh, they have no hope, people that had family members who committed suicide, those different types, okay? And any mention of suicidal thoughts plus plan in the vignette, the answer will be usually uh, take urgent safety measures, like, if they have any intent, whatever, you hospitalize them immediately. Okay? So if you suspect this person might be suicidal, على طول straight hospitalization. Okay? And it will be quite obvious. They'll tell you the intent. Oh, he has a gun at home or something like that, right? That is important. Uh, as I mentioned, treatment is usually SSRIs, so sertraline or citalopram or any of the other ones, or SNRIs along with CBT, so cognitive behavioral therapy. It takes usually 4 to 6 weeks for antidepressants to work. If one class doesn't work, you try another one. Um, People with only severe depression will be given electroconvulsive therapy. Uh, yeah, and one thing about major depressive disorder is that a lot of the questions are just major depressive disorder, but you will be confused and you'll think of 10 other things because of how they phrase it. So you need to do SIG-E caps for every single one of them. Okay? So if any caps is present and it's been more than 2 weeks, most likely MDD. Okay? So please, like when I would be doing questions, you would always I'd be getting confused a lot and thinking, okay, SIGI caps, if it's something else, and confuse it with another disorder. But uh just the way to avoid doing that is to always have SIGI caps in mind, knowing that okay, more 5 or more along with 2 weeks, this is definitely major depressive disorder. Okay. Uh there's a bunch of other major depressive disorders, okay, that we can discuss real quick. So you have we discussed the psychotic features one. Uh, we have persistent depressive disorder. So this is also known as dysthymia. Okay. It's a chronic milder depression. It lasts 2 years, so 2 or more years, and it's a 1 year in a child, and there's no break for more than 2 months in between. Okay. Which basically means that it doesn't stop for more than 2 months. So they'll have this happening for at least 2 years, but there will be no point that's more than 2 months in that 2 years where they didn't have depression. And the patients will always tell you like, oh, I've always been this way, and they'll have low mood most days, but they might not meet the full criteria of major depression continuously, and they can still have like major depressive episodes on top of it, like on top of this, they can have major depressive episodes, and the exam, might describe the person as like being mildly depressed for as long as they can remember. Okay, that's like oh, they've always been depressed. Okay, and that's like dysthymia. Okay, so 2 years, 1 year in a child usually does not come in a child, but more of like 2 years for elderly people, and they'll tell you like oh, they've never in their life had like a month or whatever, 2 months where they've not been depressed, something like that. Okay. Uh, the other one there is called seasonal affective disorder, or now it's called like MDD with seasonal pattern. Depression, which usually just happens with like different seasons. Uh, so typically in the fall and the winter, the person is depressed and they resolve in spring. And the treatment for this is light therapy. I'll repeat that again. Treatment for this is light therapy and antidepressants. And again, I've had questions like these come up, so need to know the treatments for all. And even though you'll think, oh, who's ever going to ask me about like seasonal disorder? There are people that have it, and they do ask them. Okay. The other quick ones I want to mention would be uh, so there's something called premenstrual dysphoric disorder. That's like you know significant depressive and like physical symptoms that usually happens in like the I don't know if you guys remember like luteal phase of pregnancy, of most menstrual cycles, and that's improves after like menses is done. So like that's one of them. Okay, so it's called premenstrual dysphoric disorder. Usually treated with just SSRIs if it's not finishing, but in usual it's just they can ask that question. Oh, is she does she have MDD? No, she doesn't have MDD. It's just something to do with the luteal phase of her menstrual cycle. Okay. Uh, Another thing I would like to mention would be the difference between normal grief and so that would be bereavement and major depression. So normal grief is like, okay, after loss, a person's going to be sad, insomnia, poor appetite, even, uh, maybe they'll see something, okay? But normal bereavement is generally uh, the person's still able to function. And the sadness, they have sadness, but it comes in waves, okay? And it's spaced out with positive memories. And their self-esteem is still preserved, so they don't generally feel worthless. And this is very important because there will always be a scenario of, okay, this person's wife died or husband died, whatever, and now are they depressed or are they bereaving? So this is a normal grief. How will you know? Okay. And this is why we're discussing right now. So you'll know because a person that's normally breathing, okay, he'll still be able to function. Okay, his life is not going to end. He'll be very sad and he'll have moments that are going to be sad, but then he'll have positive moments as well. And he's not going to like feel worthless. In MDD, their mood is persistently bad. They often have guilt. They feel worthless. They don't anticipate they'll ever be happy, and you know they might even like uh. So it doesn't usually include psychosis, okay, unless that's a different disorder then, okay. Uh, yeah, that's basically a big difference, okay. I hope that makes sense. Uh, Also the grief, the bereavement part, they can also last for long. Like, there's something called the persistent, again, this is getting into more disorders that maybe I should have added a slide for that, but again, these are just a bit too much. But like persistent complex bereavement disorder is the thing as well, in which is basically having prolonged grief. Okay. But again, all of that still is not MDD. Okay. Just wanted to let you know. Uh, a quick on just postpartum depression and blues and psychosis. Most common, this is also a common question, and they commonly ask this as well. So this is very high yield for you to know. Postpartum blues are the most common ones. First 2 weeks, the mom is like cheerful, moody, but she still cares for her baby, and there's no psychotic symptoms. It's transient and it self-resolves, and about 10 days it'll just be, normal. Okay, just provide support and follow up, and you'll be good. Postpartum depression, typically 4 to 6 weeks, uh, and it meets the criteria of like, major depressive episodes, and with a bit of anxiety about the baby as well. It might include like, oh, anxiety about, the baby, not being able to care for the baby and whatnot, and usually needs treatment, so therapy and SSRI. Uh, and if so, there's a new mother, she's like, at her 6 week checkup, she comes up and she's still feeling down and she's not sleeping, even when the baby's asleep, and like, she's feeling guilty and she's having like, intrusive thoughts. That's most likely postpartum depression. Okay. Postpartum psychosis is quite rare, but it'll be very obvious when they get you the scenario, right? So its onset is like within 2 weeks postpartum, and the mother has like delusions of like and hallucinations, delusions or hallucinations. And often they're related to the baby. So like they hear voices that'll tell you to harm the baby. And yeah, the risk is higher in people that have previous bipolar or psychotic disorders. Okay. And this is a very, very, very like an emergency situation in which you على طول you'll hospitalize the patient. Okay. Again, because they're most likely in these scenarios, they try to harm the baby. They'll try to kill the baby. And this has happened. Real life has happened. Okay. In which they feel this way and they kill the baby because they just hear voices. So if a question is telling your mother who believes her infant is like, possessed or something, and they try to harm the infant, postpartum psychosis, على طول, hospitalize and start antipsychotic medication to make sure the baby is safe. Okay. And yeah, I think we'll stop at this. The next thing I think is anxiety, and we'll come back from Salah and we'll discuss this. So far, if you guys have any questions or anything you guys want to discuss, let me know. If not, we can go on break. Does that make sense?
Thank you so much, Doctor. Do you think we
Uh,
can start at 4 again?
sure, yeah, we can start at 4. I think it shouldn't be that much anyways. We should be finishing. Yeah, we can start at 4.
All right. Thank
Thank you,
you.
Doctor.
You're welcome. Okay, so we stopped at anxiety disorders. So, uh, anxiety disorders are basically marked by, excessive fear or worry that is difficult to control and causes a lot of dysfunction. Okay. So there's a lot of, specific triggers uh, that might cause it. Okay. And we're going to discuss a couple of disorders that happen. So the first one is panic disorder. It's characterized by recurrent unexpected panic attacks and persistent concern or behavior, uh, change in behavior that's caused by them. And a panic attack is a abrupt surge of, intense fear or discomfort that happens very quickly. Like in a couple minutes, the person's going to just start, having symptoms of palpitation, sweating, trembling, shortness of breath, chest pain, nausea, dizziness, paresthesia, and they'll think they're going to die. So in a panic disorder, these things just happen out of the blue. And afterwards, the person worries for like a month about having more panic attacks. Okay. And they may also change behavior, such as like avoiding places, right? So people that have like agoraphobia, they develop fear where escape might be difficult to happen, or help is unavailable. So like avoid going to like crowds or like public transport or something like that, right? Uh, but sometimes it's a different diagnosis, but it's like agoraphobia is linked to panic disorder, right? So the key points for panic disorder is they are unexpected and uncued. Okay, there's no like actual reason for them to have a panic. Uh, if it's something that's cued or like it happens because of something, like for example, people are afraid of speaking socially, so that's social phobia. Okay, that's completely different. Okay, that's a complete different disorder. Okay, so there's no cue or there's no expected reason for them to have a panic. It also, in a panic disorder, you have to rule out any symptoms that might be like medically occurring. So like a thyroid storm, or people that have pheochromocytomas or like arrhythmias that cause symptoms. So these also have to be ruled out. Like a pure panic disorder, no medical workup is usually negative. Okay, or is negative. Uh, so it's usually, uh, you know, the diagnosis is usually, as I mentioned, is after the attack, the person is followed by, 1 month of like persistent like fear or worry about the whole thing happening again or having a change in behavior. Okay. The mnemonic to remember, this would be like panics. So palpitation, abdominal distress, nausea, intense fear of like dying or losing control, chest pain, chilling or choking. And S would be like sweating, shaking, shortness of breath. Okay. Sometimes I also believe they have like having a heart attack or something, right?
And the treatment is SSRIs or SNRIs are like first line for panic disorders, along with like CBT. Benzodiazepines can be used in like short term, okay, because they relieve panic very quickly, but because they are like very dependencies like a fear, so you don't really use them long term, okay? Uh, so like in an exam scenario, if a patient is like in the ER hyperventilating with a panic attack, a fast acting like benzodiazepine is like appropriate acute management, and for long term, it's going to be like SSRIs, okay? So that's like a panic disorder for you. Specific phobia, so I just mentioned that briefly a bit, is like the intense, irrational fear of a specific object or situation, which leads to avoidance. So the fear is like, is out of proportion to the actual danger. So for example, a lot of people have like fear of spiders, so that's like arachnophobia, or like heights, like blood, any of this, right? So they just have like severe fear. And the person will already know the fear, and they know that it's excessive, but they feel anxious about it, right? So the treatment for that is like gradual exposure therapy. So you desensitize them, okay? And and yeah, that's basically it. But like for short acting, they give them short-term benzodiazepines, okay? Uh, So please know the difference between specific phobias and panic disorders. Panic is uncued and unexpected. They'll have a panic. This one, they know what it is, and they already know that they're going to have this, okay? Uh, there's something known as social anxiety disorder, which is also a kind of specific phobia, but it is intense fear of social situations. So they can't go or perform socially because they're worried about embarrassment or like negative evaluations. And uh this can be generalized, so fear of most social interactions or like a specific thing, like public speaking only. Okay, so some people might just be like, oh, I can't go out at all, or some can be like, oh, I'm good with going out, but I just can't, I don't want to go on like a stage and speak. Okay. Uh, so some people might have panic symptoms when speaking uh in public, and they'll just have like anxiety and like start having all those symptoms we mentioned, the panic symptoms, PANICS, okay, those symptoms. So if it's performance type, we usually give them beta blockers or benzos for that specific one. Sometimes people, some people take like their exams, taking their board exams, step one type one. They'll also take they're really afraid of them, so they take benzos or beta blockers. I'm being very serious. I know people that planned on taking these for their exams because they're quite afraid. So yeah, in regards to the general type, usually treated with CBT, SSRIs. Okay, that's usually treatment. Uh, yeah, these are the general anxiety. These are the a bunch of the quick ones that we discussed, and we discussed uh, agoraphobia as well, which is basically irrational fear, or anxiety, uh, in specific situations. So like open spaces or lines or public transports or whatever. And again, these are like specific phobias, all of them. Okay. And one thing I didn't mention would be it has to be for more than 6 months. Okay, for specific phobias. Okay. Uh, we'll discuss adjustment disorder, and then we'll go into the big topic that is general anxiety disorder. So adjustment disorder, this is one of the most annoying ones for me personally because a lot of the things, this is a very confusing one. So adjustment disorder is having excessive anxiety or depression, okay, that occurs within 3 months of a identifiable stressor, okay, and it usually lasts less than 6 months once the stressor has ended. Okay. So the symptoms, like, so the stressor would be like a divorce or like, job loss or whatever. And it usually doesn't meet any other criteria. Okay. Uh, and like the symptoms are distressing, but they resolve, as I mentioned, in 6 weeks, 6 months, as soon as the stressor ends. But if it persists beyond 6 months, it's no longer adjustment disorder and it's something else. Okay. The treatment is usually, psychotherapy, CBT, and it's not usually meds. So for example, a man develops anxiety and insomnia after being laid off, and then, starting within weeks of the event, and if it's clearly linked to the stressor, it's usually the adjustment disorder. Okay. Uh, the issue with this is it usually gets confused because it's not really clear. It could be a lot of things could be adjustment disorder. So that's why I mentioned initially, always look at SIG caps, uh, look at dig fast, look at these ones and make sure it's not those. And if it's just something that's, either anxiety or depression, those are the ones you can just, you can rule those out. Okay, then it's adjustment disorder. Okay, as long as it's not meeting other things. Okay, I think that's basically it for adjustment disorder. Uh, Let me. Did I? Okay, sorry, I skipped past general anxiety disorder. That's my fault. General anxiety disorder is basically uh the big one in this category of these disorders, and it's basically having excessive anxiety or worrying a lot about, just a bunch of aspects about your life. Okay, so it could be work, health, finance, just any matter. Okay, and it occurs like, it happens like almost daily, okay, for like 6 months or more. And it's difficult to control and is associated with like symptoms such as like, fatigue and like difficulty concentrating. They have, muscle tension, they're irritable, they don't sleep much, stomach pain or something. And they're worriers, they're like chronically worrying about everything. Uh, and it's not like tied to anything specific. And they always say like, oh, I've always been a worrier, and uh they'll always just worry about like their kids and their job and their bills, and even if everything is going well, this is just them. Okay, so this is what a chronic so generalized anxiety disorder is going to be like. Okay, and treatment with this is usually, SSRIs or SNRIs are like first line, and CBT is also there. uh what's it called? How do you distinguish uh what we just mentioned, general anxiety disorder, from adjustment disorder? Is that if anxiety is limited to within 6 months with a specific stressor, that's adjustment. If it's more pervasive and long-standing, you would assume that's general anxiety disorder. Okay, I hope that makes sense. Uh, in general, these are the differential diagnosis for, the anxiety disorders. We went over all of them. Specific phobia. So we'll start again from the top. So social anxiety disorder is like a type of, specific phobia, but specifically just outside. Uh, see, there's a comment. Okay, someone's asking if I've heard of this term being thrown around is healthy anxiety, and I want to know it's part of general. I mean, no, I don't think that term. So healthy anxiety would be, I don't know if it's a medical term. I haven't heard it in whatever I've studied. Healthy anxiety is like there should be a healthy level of anxiety in a person towards, for example, you should have a healthy level of anxiety that keeps you going for your, neurology exam. Or there should be a level of anxiety for, okay, as Muslims, Ramadan is coming and, I'm anxious to, okay, let me prepare for this, or, let me prepare for my prayer. Or if I have bills coming up, I live alone and I should have a healthy level of anxiety, which is like, okay, I know this is coming up. Okay, I have to plan, I have to do things for it. The pathological level is like going over the top and like, oh my God, this is happening and this is, and over every single aspect of your like life. Okay, so I would assume that's what it means, and I hope that answers your question of healthy anxiety versus not healthy anxiety. Okay, thank you. Okay, you're welcome. Uh, and yeah, this basically just summarizes what we just discussed. Now, obsessive compulsive disorders uh is basically characterized by, obsessions, which are recurrent, intrusive thoughts, impulses or images that, that would mark anxiety, like, oh, germs, like germs are everywhere and I feel like I can't touch someone, I'll get sick. So that's like an obsession. And compulsion. So the person is either having obsessions and or compulsion, so like repetitive behavior, or mental acts one feels they have to do to to reduce anxiety. So they usually have to wash their hands multiple times or lock the doors multiple times or something like that. That's like a repetitive behavior just to reduce anxiety, okay? And they say so it's obsessions are ego dystonic, okay? And that basically means that the patient realizes that these thoughts and behaviors are like unreasonable, but there's no way they stop them, okay? Like they can't stop them because this is the only thing that gives them like, uh comfort. Like this is their like, okay, this gives me comfort. Like I think this is gonna stop the anxiety or feeling I have inside of them. Okay. This is different from obsessive compulsive personality disorder, where it is ego syntonic and they see this as correct. So for example, you have medical students that are obsessively compulsively uh they have this personality, okay, so they're correcting everything and so on and so forth, okay. So this is syntonic, sorry, where they'll think, okay, this is necessary for me to do good, this is not a bad thing, okay. While ego dystonic is like, okay, I know this is bad and I know this is weird, I'm doing this 10,000 times, but I just can't go to sleep unless I put the lights down 50 times before I sleep, okay. That's what it basically means. uh OCD patients know their behavior is bad and it's irrational, but they feel compelled to do it, and as opposed to the other one. Okay. Uh, so what is the treatment for obsessive compulsive disorders? It's usually SSRIs, or a TCA, which is effective, so clomipramine. Also CBT with exposure therapy usually helps, and it's very effective. Uh, And yeah, this is usually often a meds plus therapy type of situation, okay? Body dysmorphic disorder is pretty straightforward, where they're pretty preoccupied with how they look, and they always are like, oh, I don't really look this way. Like they're really, the way they look at themselves is not actually how they look, okay? And it causes like severe problems. So like, they look in their mirror a lot, they check themselves a lot, they groom themselves a lot, and yeah, it's not in you'll see like, oh, people going to the gym, they're pretty big, but they think themselves of like really small. That's like, body dysmorphia. Okay. Uh the next one is PTSD. Uh this one's pretty straightforward. Once a person goes through a life-threatening experience or a traumatic one, uh they they start to have this stress disorder, which the core symptoms will be like, they feel intrusive. They have like intrusive thoughts, like, okay, so nightmares and flashbacks and like intrusive memories, and they'll try to avoid the reminders of the trauma. So like negative alterations in mood and cognition as well. Like they'll have bad beliefs, negative beliefs, and blame themselves, and they have inability to express positive emotions. So it's just severe levels of negativity, and like they'll have hyper arousal, which is like they're always on like they're hyper vigilant. They're always like checking around, and they're startled, quite exaggerately, and like irritable. Also have insomnia as well, and this has to have lasted at least a month. If it's less than a month, if it's acute stress disorder. Okay, so more than a month, PTSD. Less than a month, ASD. ASD has to be from 3 days to a month, okay, after trauma. And treatment is usually psychotherapy. Uh, so in regards to PTSD, there's a mnemonic they use here is called HARD. So hyperarousal, avoidance, re-experiencing of the events. They'll see flashbacks and whatnot, and they're usually in distress. Uh, Treatments are, as I mentioned, is going to be trauma-focused psychotherapy. So they have, rapid, so eye movement desensitization. There's something called EMDR, eye movement desensitization and reprocessing. That's a therapy. And like CBT, and SSRIs are also used. Uh, Parazocin is usually helpful with nightmares. But you have to avoid something, benzodiazepines, okay? You'll avoid benzos in PTSD. They're not recommended for long term, okay? Usually in exam, you'll see, okay, veterans who came back from the combat and, he's hyper alert and, he usually does not want to talk about what happened. And it's a classic PTSD scenario. And if it's just been like he recently came back, okay, so ASD scenario, okay? Uh, what is PTSD versus adjustment disorder? How are you going to differentiate? Okay. So PTSD requires like a specific traumatic event. Okay. So actual threatened death. Okay. I see there's a question real quick. Uh, yes, they are similar. So so the question is, are the symptoms for PTSD similar in kids and adults like in war situations? Yes, I mean kids that have gone through the terrifying experiences of war, they usually have nightmares. They don't like talking about it and they avoid a lot of stuff and they're hyper arousal as well, so they're like quite quickly startled. I know some of you guys might have seen the images of the recent wars that and the conflict that's recently going on. You see videos of like the kids that are crying constantly. Any noise that happens, they're quickly up. So similar symptoms. Okay. I hope that answers your question. Uh, so I was trying to tell you guys, okay, how are you going to differentiate between PTSD and adjustment disorders? Okay. Real quick, there's a comment. Okay. You're welcome. So PTSD requires a specific traumatic event. Okay, so actual, life and death situation, some sort of serious injury, sexual violence of some sort. Uh, and the symptoms are, as we mentioned, right now, the ones that are here. Adjustment disorder can be any non-life threatening event. So it's like, oh, someone lost a job or, divorce happened or something. And it doesn't have the flashbacks and nightmares and all of this. Okay. This does not happen in an adjustment disorder. Okay. So know the difference because once you're doing questions, you'll be very, okay, is this an adjustment disorder? Could it be? So look at into the exactly what happened. Okay. Uh, in regards to acute stress disorder is literally what is PTSD, but it's less than a month, more than 3 days, less than a month. If it lasts for more than a month, it does become PTSD. About half the cases of acute stress disorder become PTSD. And again, treatment is supportive therapy and short-term meds to reduce the anxiety and insomnia. Uh, the other things I wanted to discuss would be real quick. I think we're wrapping up the presentation here. Is other disorders that are kind of related to OCD. Okay, so trichotillomania, which is basically hair pulling. This again, you'll be like, why are you teaching us this? This comes in board questions, and I've had this, and one of my favorite questions because it's very easy to tell. Okay, so recurrent pulling of one's hair, and it causes notable loss. It's usually around the scalp and eyebrows as well. And I actually have a friend that does this. He pulls out his hair as well a lot. So I don't know what you guys can do with that information, but to tell you that there are real life people that actually have these. So yeah, it's often associated with like stress, anxiety, tension, whatever, and this food gives them relief. Actually, now thinking about it, I know two people. One person that pulls their mustache when they feel thinking or whatever. Another that pulls his arm hair. So yeah, forearm hair. So yeah. Anyways, the patients, so they have like patches of hair you'll see of different lengths, and they'll tell you they're not pulling, but they actually are. And then uh, it's like basically patchy hair, and we'll have broken strands. Okay, that's what they mention. Okay, and some of them will also put their hair in their mouth and like they swallow it as well. They like chew on it, like not chew on it. They put it in their mouth and like swallow it in. Okay. Uh, so how do you differentiate between trichotillomania or alopecia? So alopecia is more of like autoimmune, while trichotillomania is like impulse control disorder, OCD kind of thing. Okay. Again, one is like autoimmune, so it's like T cell mediated, while the other one is like, anxiety, OCD kind of. The trichotillomania is irregular patches, broken hairs are going to be found, and they're going to have varying lengths. While alopecia, as you can see, is like it's very well demarcated, and you have smooth bald patches. Uh, it's gonna have like smooth skin, no broken hairs, none of that. While the other one has like, well, trichotillomania has like uneven stubbles, like twisted broken hairs, and different lengths, as we mentioned. Associated features might be like, because alopecia areata is like a autoimmune disorder. You can have like, pitting nails, vitiligo, and other, atopic conditions like asthma, eczema, or something. While for trichotillomania, it's, they have OCD, anxiety, something like that. They might have other of those disorders. Uh, Basically for trichotillomania, you just give CBT, and you do habit reversal therapy, and like maybe SSRIs if they're not really going for it. Um Alopecia, I mean, not really a topic, but like treatment is usually like steroids or like JAK inhibitors because it's autoimmune. Okay, and this is like a picture of like a gastric bezoar, which is like the hair that's collected because of them eating it. Okay, let me see how I can go to the question. Someone asked a question. Okay. Is hair loss from either condition reversible? I mean, so trichotillomania is reversible because you're pulling it out, so it's just going to grow out. The other one is an autoimmune condition, so this one is not like reversible in that sense unless you treat the autoimmune condition. Okay? I hope that makes sense because trichotillomania is you just pulling your hair out. Okay? So you could start pulling out your hair, it's going to grow back. And the other one is just, yeah, you're welcome. So here, we're basically coming towards the end, and this would be the last thing I want to discuss and give you a point is that, we went over major depressive, dysthymia, adjustment disorders, and all of these. So the idea I want you guys to have is that, as I mentioned in the beginning, that social and functional impairment is very important and something that's very significant in all the psychiatric disorders. Uh, Always look for any drug-related problems or if you have any other medical conditions. And it should be, you should have a good idea of how to differentiate between normal stress response versus, this is anxiety, this is something else. Okay. Uh, yeah, I think that's it for today's presentation. Please let me know if you have any questions. I hope this was helpful and give you a better idea. And yeah, let me know if you have any questions. If not, we can end it here. And inshallah, Badr's gonna take over tomorrow and give you a better idea of what's to come next. Okay. You're very welcome, Zainab. Thank you for interacting throughout. Jazakallah khair. Okay, all right. Well, Ramadan Kareem to all of you guys. Hope you guys have a blessed month. May Allah accept our good deeds and make us one of the fortunate ones that are forgiven from the hellfire. And I mean, and yeah, Assalamu alaikum. Hope you guys have a great day. Thank you very much. Bye bye.
Thank you so much, Doctor.
Welcome.